So a man walks into a dental office for wisdom teeth removal. He's overweight, but cleared by his doctor. Vitals look good on the monitor. He's relaxed. Sedation begins. 10 minutes in, he stops responding. His oxygen drops. You attempt a jaw thrust with no effect. You reach for the airway adjunct, but it's too late. Now you're bagging a patient who wasn't supposed to crash. This wasn't an emergency case. It was a routine outpatient procedure. So what went wrong? Welcome, everyone. My name is Dr. Mark Shankman. I'm an oral and maxillofacial surgeon that deals with this kind of stuff all the time. Today on the Obesity Project, we're talking about obesity and airway collapse, the dental sedation risk no one's talking about. So this is episode 74. Thank you for joining me. So what went wrong was already there. Before the IV, before the syringe, before the sedation, it was his airway and it was his insulin resistance. Because obesity doesn't just affect blood pressure, it physically changes the airway and metabolically weakens the system that keeps it open. So sedation doesn't cause the collapse, it reveals it. So the airway in these situations is already compromised in obesity. So we have a couple things that happen in obese patients. First, the pharyngeal wall, or the walls of the throat, become thicker. The tongue base becomes larger, and a larger tongue base blocks the airway much, much easier. The soft palate in the back of the throat, it hangs lower and gets much closer to the tongue so that the tongue can obstruct and block the open airway. And then also neck circumference, the circumference around the neck, it becomes wider. So there was a 2014 study in Chest, the journal, that found that pharyngeal fat volume, or fat around the neck, was directly correlated with airway collapsibility under sedation. And this was a study by Schwartz et al. In 2014. So imagine breathing through a straw. Now wrap that straw in a large amount of soft tissue. That's what sedation feels like to an obese airway. So the second thing that happens is obese patients desaturate faster and rescue is slower. So even with nasal oxygen, obese patients have lower functional residual capacity, meaning when they blow out, the amount of air left behind in the lungs is the residual capacity, and they have a lower amount. So that means that their oxygen levels will decline faster. They also have less room to coast when breathing stops. So many of us, if you're healthy and you're lean, you can actually hold your breath and your oxygen saturation, or the amount of oxygen in your blood, doesn't drop all that rapidly. But when you're obese, you get a faster oxygen decline, and especially happens under stress. So there was a 2006 paper in Anesthesiology that showed that in obese patients, oxygen saturation dropped twice as fast as in lean controls during mild apnea. So an apnea being the lack of breathing, right? Someone stops breathing, that's called apnea. So let's talk about an example. So in a 170-pound patient, you may have 2 to 3 minutes to intervene if they stop breathing and the oxygen starts to desaturate. They lose oxygen in their blood. So that 170-pound patient might have about 2 to 3 minutes to intervene. What happens in a 280-pound patient? They have less than 60 seconds if you're lucky. And so time becomes much more critical, and it's definitely something that we have to anticipate and react to when the heavier person, the obese person, starts to drop. So the third thing that happens is sedation dulls the alarm bells. So conscious sedation, or many people call it a twilight sleep, relies on the body's reflexes, things like tongue tone, diaphragm control, and positional compensation. So in other words, the position or the the amount of muscular tone inside the tongue, it creates tongue tone. Diaphragm control, how well you're able to expand the diaphragm and get air into the chest cavity. And then positional compensation means if I lie someone back, they can compensate for that change in position where an obese person cannot. So these three things happen, but when you sedate an insulin-resistant patient, those reflexes, they weaken and the signal gets delayed. And what you're left with is silence until desaturation hits. And that, again, that's the lack of oxygen in the blood. And if that goes for an extended period of time, now you're looking at, potential brain damage and or death. So in the Journal of Oral and Maxillofacial Surgery in 2019, they reported that people with BMIs greater than 35, which is body mass index, tripled the incidence of sedation-related airway obstruction, so blockage of the airway, even in procedures under 30 minutes, which are the vast majority of the procedures that I do when we're sedating patients. So let's talk about how we can prevent this. So this isn't a call to avoid sedation. It's a call to understand your patient's terrain. It's a matter of understanding that in obese patients, we have to work faster and we have to take into consideration some of the things that change compared to a lean person. So some things that we have to ask preoperatively, do you snore or stop breathing at night? Have you ever used a CPAP machine, which is for obstructive sleep apnea? And what's your neck circumference? So these questions are really important to get a good gauge on what someone's likelihood of obstruction or blockage of the airway and lack of oxygenation to the brain ultimately is what happens if they get obstructed for too long. Some of the sedation strategies that I use and many other oral surgeons will use is using a drug called Precedex and or ketamine when appropriate. And many of you probably have heard of ketamine. It's a very, very useful drug as part of a sedation regimen. I know that it's out on the streets and everybody's afraid of it, rightfully so on the street, you should be. But these two drugs, Precedex and ketamine, they preserve airway tone, so they become really extra important to consider on an obese patient. So we also want to consider pre-placing a nasopharyngeal airway. So that's a soft rubber tube that gets placed in the nostril, goes back through the nasal cavity and behind the tongue and allows air to pass. So it's not a breathing tube, but it's something that kind of holds the tongue forward and allows the air to pass through behind the tongue so the tongue can't block off the airway. We also want to pre-oxygenate very aggressively, meaning we want to blast patients with oxygen at a high level, almost uncomfortable level, and do it before we start the procedure. And we have to do it very aggressively. We can't do it passively. So on a regular lean person, on someone with a BMI of like 25 or less, I might just put the oxygen in the nasal cannula, the little prongs that go in the nose. I might use a level of about 2 liters per minute, but on an obese patient, I might move it up to about 4 liters or 5 or 6 liters per minute. That will dry the airways out and people don't like it, but pre-oxygenating aggressively is really important. Also, we want to monitor end-tidal CO2 rates in all high-risk cases. So end-tidal CO2, we're actually in the nasal cannula in one end, the oxygen is going in. On the other end, carbon dioxide is coming out, and that's being measured. So that's end-tidal CO2, where the carbon dioxide comes out, and we want to monitor that because the level gives us an indication of what's going on, but also that carbon dioxide monitor is seeing waveforms that tell us that the patient is breathing and they're not obstructed. So in the 2021 guidelines from oral surgery, oral medicine, oral pathology, that's a journal, they recommended customized sedation protocols in obese patients and reducing that reduce unplanned interventions by over 40%. So let's get to the real root of and the real root of the problem, which is insulin resistance. So we think of airway collapse as purely mechanical, but it is also metabolic, and we need to keep that in mind. Insulin resistance leads to things like increased soft tissue inflammation, which can affect the airways, and airway inflammation is one of the leading causes of people having asthmatic attacks, something called laryngospasm, where the vocal cord snaps shut to try to protect things from going down in the airway, but also blocking off the airway as a result. So these types of things can happen, and these all happen in response to soft tissue inflammation. We can also get fluid retention in the neck, which can obstruct the airways even more and increase the neck circumference at the same time. And we can get a loss of neuromuscular control. So the muscular function is not as good, maintaining tone in the airway, which causes collapse, and the nerves not working as well either. So in order to fix the signal, you need to reduce the risk. And that's why we want to use things like a low carbohydrate or carnivore diet, or a ketogenic diet. All of these things are kind of related. You want to get some fat loss from around the neck, and you want to lower fasting insulin levels. So these things aren't just for the scale, they're also for the airway, and improving your risk when it comes to doing open airway procedures like we do in oral surgery. So this has been episode 74 of the Obesity Project. Obesity and airway collapse, the dental sedation risk no one talks about except me. I'm talking about it. If you're sedating someone who's obese, don't just watch the monitor. If you're a patient being sedated, you have to understand that you're at increased risk of airway obstruction, and your doctor has to be privy to that and has to be ready to respond at a moment's notice. I have to constantly watch the patient, watch their airway, and remember that they're already walking in with a risk that no one measured. So this isn't just about better protocols, it's about metabolic preparation. And don't forget, here on the Obesity Project, we're cutting through the myths and getting to the root. So thank you so much for watching. Again, my name is Dr. Mark Shankman, an oral and maxillofacial surgery that does these types of procedures on a daily basis. It's really important to understand that if you're obese, if your BMI is 35 or above, you are at increased risk. If you're at 45 or above, you probably shouldn't be doing open airway procedures in the office. You shouldn't be having open airway procedures in the office. And in that case, you really need to be intubated with a breathing tube. And there aren't too many places that you can get that done. That's ultimately the problem. I'd love to have more patients intubated and on ventilators, but the reality is, in an office setting, like in the oral and maxillofacial surgeon office, you don't really have that option available to you very often. So thank you so much for watching. Make sure to share this with any of the folks that you know that are at risk, that need to understand that they are at risk, and need to understand that their doctor needs to pay closer attention and be ready to respond at a moment's notice. And hit that subscribe button for great continued content from me, and hit that bell notification so you can know when the videos come out. So thank you so much for watching. I certainly appreciate your attention. Hope you learned a little something. I will catch you in the next video. Take care.